moving along, the next talk is an important talk. It's about navigating the congenital heart patients in heart ICU. Gives jitters to a lot of fellows in the ICU. And we have Dr. Hardin to give this talk. Thank you very much.
All right, well, thanks for inviting me, and I know you paid to see my partner, Man Jokadar, who frequently attends this meeting. But those of you in the Rochester Mayo Clinic campus are getting a good guy. He's busy getting ready to relocate. He's handing off the leadership of the program to me, and I got lucky enough to be invited. So again, I look forward to taking some of the knowledge I've learned here and doing better in my job. So we're going to talk about some of the unicorns of the cardiac world. And I think most of you in the cardiac intensive care unit domain know how challenging these patients can be. So I hope I make it a little easier for you. And I also want you to know that we're in it together. And when it does get tough, there's at least 500 of us in the United States you can call in now. All right, so it isn't your imagination. These patients are increasingly being hospitalized, and the hospitalized ACHD patients coming in sicker, more complex anatomy, more comorbidities, and hopefully today we'll explain a little bit why. I want you to understand the hazard specific for two of the most commonly encountered congenital heart diseases among hospitalized ACHD patients. We don't have time for much more. And then some of the key similarities and differences that you'll be seeing in the care provided to ACHD patients with heart failure and arrhythmias as compared to adults without congenital heart disease. So, kids say the weirdest things. There's two, you may know this, there are two pathways to becoming adult congenital heart disease board certified. It's a specialty of internal medicine. It's not a subspecialty of cardiology. It sits out there all by itself. And you can get there by being a pediatric cardiologist or a cardiovascular internist. I went the former, pediatric. And one of my teenagers said, as he observed all of us together, like you guys in this room, he said, "You know what you folk remind me of? The Planet of the Apes." And I said, "Well, why is that?" He says, "Well, the intensive care docs and the interventional cardiologists, they're like the gorillas. They're just very gruff, and they get the job done, but they have a different personality than the medical people in the clinic. They do weird things. The chimpanzees of the world are the general cardiologists." And then you might want to know who I think, and I think the guy got it perfectly right when he told me, who are the mystics, the orangutans? It's the electrophysiologists. They look at things, and we general cardiologists say, "What are you seeing, and how is that possible?" and so on. And then there's the adult congenital cardiologist, the newest specialty, 2015 first board exam for ACHD. We're the Tarsius monkey from the island of Bohol in the Philippines. Very few of them. You have to go a long way to get them, and when you do see them, they like to hide. And you all know it's sometimes hard to find us, and I apologize for that. All right, so this is a tsunami. It's coming your way. 90% of children born with congenital heart disease are surviving into adulthood. It is expanding exponentially. So if you're not seeing adult congenital patients now, you will tomorrow. And the most common reasons for hospitalization are heart failure and an acutely symptomatic arrhythmia. And you can see in this Canadian cohort in the graph there, the numbers are increasing just very rapidly over the first half of this century. So get ready. And you'll see other reasons for hospitalization. Of course, we operate, we do interventional procedures, but bottom line is this: get ready. And then also realize that the patients are going to come in different than the existing adult patient with heart disease. There are significant barriers to healthcare. Many of them don't work, can't work, aren't uninsured. They live with somebody who cares for them, have many disabilities, genetic syndromes. They're hard to take care of. So heart failure and arrhythmias, well, one problem begets the other. So this is how I think about it. 1 out of 3 patients in the adult congenital population will have an arrhythmia, will have heart failure in their lifetime. And the typical tip of the iceberg phenomena applies. If you look at their childhood years, they've grown with a hypoxemic circulation oftentimes, one that's been palliated sequentially over many operations, and they acquire significant cardiac remodeling and decreased cardiac reserve. And then there's other things that you get when you get older. We all know, and you heard today, some of the things like obesity, diabetes, and such, et cetera. So lots of things conspire against these folk. And half of these people will get a significant arrhythmia. So get ready. AFib, A-flutter, very common, sinus node dysfunction, heart ventricular arrhythmias, and a lot of people getting pacemakers for one reason or another. So I'm going to spend a little time on two topics. Tetralogy, because it's the most commonly hospitalized patient. Not necessarily the highest acuity, but you're going to see these patients hospitalized mainly related to complications of chronic pulmonary regurgitation, right heart failure. And arrhythmias do supervene, and when they do, it usually means there's something wrong with the anatomy. It comes in much earlier. This is not, the 50 to 60-year-old AFib. This is the 20 to 30-year-old with AFib. And as they age, most of them are going to need a pulmonary valve intervention. Thankfully, about 80% of them will be a candidate for a catheter-based valve intervention instead of surgery. But arrhythmias really start to spiral as you get higher and higher in the age bracket. The other one that I wanted to mention briefly is Fontan palliation of single ventricles. Not as common, but extremely vulnerable and fragile. And this is a significant population of hospitalized ACHD patients in the ICUs. They typically are exceeding survival rates of 80% now, so they're not as tough to care for as children as they used to be. They have lots of comorbidities, and the typical 40-year-old Fontan has the same life expectancy as a 75-year-old individual without congenital heart disease. So they're very, very difficult. And the imaging, everybody's different. Every anatomy of a single ventricle may be different. The palliations are different. It's very hard to take care of this in a standardized way. So what about the arrhythmias? Just a couple brief points. Tetralogy, ventricular tachycardia. Think about that. There are QRS durations that are wide, LV dysfunction, RV dysfunction, better be ready. Fontans, think about sinus node dysfunction and atrial arrhythmias, lots of sutures in the upper heart chambers. Epstein, ventricular preexcitation, lots of patients with Epstein's have multiple accessory pathways, very high risk for sudden death if they have that. The mustard or sending operation, the atrial switch, not the arterial switch, but the atrial switch, very high risk for sudden death. And Eisenmenger syndrome, fortunately pretty rare. So I think what I'm going to say at the end here is that you're going to be inundated. And I need, and I think a lot of us need more people interested in our field. Train more adult congenital cardiologists. Heart failure phenotypes vary, and the arrhythmia management has to look at the anatomic structural vulnerabilities that predisposed. And you're going to help these patients grow older. They're already on the way. You're going to help them, and let's write their history well. Thank you very much.
Thank you very much. Panelists?
Yeah, I think the timing for referral for advanced therapies is tough in our ACHD patients. We struggle with that, especially with the Fontan, and learned a lot with Yuli Kim in our group and Stephanie Fuller. So earlier referral, the better. Yeah.
And you're going to find that transplantation outcomes are, as you probably know,
yeah,
much different in the
yep,
Fontan, the failing Fontan population, and their eligibility to be listed. Although those listing criteria are changing, yeah, maybe having some priority weight for congenital heart disease, you're not going to get a Fontan at a high priority level on a mechanical circulatory assistance device. You need a cavopulmonary circulatory assistance device, and they don't exist. So they're already excluded from one of the easier ways, if you want to call it easy, to be listed at a higher priority.
I think one of the other things too is when I started my training in Boston, we actually had a children's hospital, Boston Children's, Brigham and Women's, Beth Israel conference, and there was a lot of interplay, but we didn't see that many of these children. I think now our fellows that are training, the interventional fellows, I should say, really some of them are going to need to have a greater expertise in doing what the pediatric interventional cardiologists, at least having a better understanding of what they do and what needs to be done. It's not going to be me, but it's going to have to be some of the newer fellows coming out through training.
Yeah, there's tons of ways to skin this cat. Unless you live in Houston, where you can have your own ACHD unit. Man, I'm so jealous. We heard that yesterday. We are borrowing from our colleagues in both the Children's Hospital as well as the structural valvular heart disease programs. I like kind of borrowing from the various domains. It keeps them engaged. If you're going to catheterize somebody for congenital heart disease, you better be ready to intervene and not just say, okay, I see the problem, now I gotta have someone else come in, repeat the anesthetic, repeat the cath, all the vascular access issues. They are a bear for vascular access. And then bring in another team that could have done the diagnostics and the intervention at the very same time. I'm not a big fan of cathing to look. We can do MRI, CT for that.
Can you comment on the biggest obstruction, and you sort of pointed at it, which is really insurance reimbursement. I think Obamacare sort of extended some of the insurance coverage to some of these younger people, but if you're 40 years old and you can't work and you don't have life insurance and you don't have health insurance, I mean, that seems like has been the biggest barrier. Are we overcoming that? Are there any sort of plans to try to get these patients paid for? Because otherwise you're not going to care for them. They're going to end up in Medicaid in some small hospital, and you guys aren't going to be able to take care of them because you won't be paid.
Yeah, don't get me started. Yeah, that's every single day. In fact, to become an accredited center for congenital heart disease, you think you got to have doctors and surgeons and specialists in the advanced practice nursing domain. You really need a social worker. Yeah. They can navigate this absence of access to care much better, but it's not getting better early, at least.
I think one of the challenges in the advanced therapy is that they get to us late, and also the liver dysfunction. And it's very tricky to manage these patients with this and understand how their liver is going to work. We have done a lot of like combined liver and heart transplants because of that reason, but it becomes more challenging. But I don't know if that's something that needs to be explored for patients to be referred earlier and maybe listed earlier when they have all this liver and all these collaterals and how to manage that. There is no really guide for that one.
Yeah, no, you're right. In fact, there's two phenotypes for heart failure in our patients too. There's the reduced ejection fraction that we try and use the drug therapies and interventions that you are used to using. And then there's the failing circulation. It's just not working. Venous congestion in the liver transforms it to a cirrhotic liver, portal hypertension, venous variceal bleeding, and worst case expression, hepatocellular carcinoma. So yeah, it is probably the Achilles heel of the Fontan operation. It's the extracardiac burden of disease.
Thank you very much.
Thank you very much.
So much. We're going to go on.